Good afternoon and welcome. My name's Tim Poe. I'm Director of Telehealth with the UNC Cancer Network here at the UNC Lineberger Comprehensive Cancer Center. Thank you so much for being here today, February 26th, 2020. We're really glad to have you on board for this lecture. This is a research to practice lecture, and just a few things to tell you, and then we'll meet our guest and get started. If you have any technical difficulties at all, please call us right away, 919-445-1000, or email us unccn@unc.edu. You can find out all sorts of information about us on the web at unccn.org. I know that we've had audio issues with the last couple of lectures. We think we have those just about solved, but please don't hesitate to let us know if you're experiencing any problems. We will use Poll Everywhere today. It should be easy. It's anonymous. We encourage you to use the heck out of this. Answer every question. Why not? And this makes the whole lecture more fun and engaging. So you can join by web. Go to pollev.com. Put in UNCCN, you'll join up there. You can go and join by text by texting the letters UNCCN to the number 22333. You'll get a little message back that says you've joined, and then you're all set. And there's an app. There's a free app for Poll Everywhere, both for Android and for iPhone. You can go out and get that. Just put in the letters UNCCN. I've been using that a lot lately, and I think that's the easiest thing. We want to welcome Madison Ziegler with UNC Lenore Healthcare. She's a new site coordinator, so thank you so much, Madison. If you're interested in becoming a site coordinator for your site, please reach out to us, unccn@unc.edu. We'd love to have you on board as a coordinator for your site, helping to gather a group of individuals at your site to watch these lectures. If you would like to be a promoter and help us spread the word, forward on some information about the lectures, please let us know that as well. Lots of different ways to get free continuing education credits through our live lectures, our self-paced lectures, and then you can view things in our media site library, on our YouTube channel, or on our ViewMedi channel. All right, and without further ado, I would like to introduce our guest today, Dr. Josh Zeidner. Josh, welcome.
Thank you. Pleasure to be here. Thank you, Tim.
Thank you for being here. Let's see what we know about you. Assistant Professor of Medicine at the University of North Carolina Lineberger Comprehensive Cancer Center. Let me know if I get everything right.
You're
all right.
Good so far.
Okay. Expertise in the management of patients with acute myeloid leukemia, myelodysplastic syndrome, and myeloproliferative neoplasms.
That's correct.
Okay, good. And research focusing on drug development and the design and implementation of innovative trials for patients with acute myeloid leukemia and myelodysplastic syndrome.
That's right.
Okay, and there's more on your bio. You've got plenty of information about you, so we encourage our viewers to read that as well. What's one thing we should know about you outside of your professional focus?
I think this won't be surprising for those that know me well, but maybe surprising for some of you that have just met me or don't know me very well, but I was in a rap and hip-hop group in high school.
Great.
No longer delve in the rap scene.
All right.
But I am a professional karaoke singer, so encourage everyone to come out to the Leukemia and Lymphoma Society events that we have every year, where we raise a good amount of money for the charity based on offering our karaoke abilities.
Great.
And I think our next event is coming up in April. So.
Great. Well, we'll look forward to that. Thank you so much. All right. And we'll kick this off. I mentioned Poll Everywhere. Here's our first question. Acute myeloid leukemia, AML, starts in the, and then A is bone marrow, B is brain, C heart, or D, lung. So if you would please select which one of those you think is correct. Again, these are all anonymous, and let's take a look. And while you're doing that, I will read our disclosure. This activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. William A. Wood, MD, MPH, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. Josh Zeidner, MD, has no financial relationships with commercial interests as defined by the ACCME. Phew, got it done. All right, and already jumping into our poll, I'm seeing a trend here.
That's
How
great.
are they doing?
Everyone got it correct.
That's what you really, we have a sharp audience, so nice work, everyone. We'll look for more answers. And without further ado, management of acute myeloid leukemia in 2020, a paradigm shift for older adults. And I'll pass the controls over to you.
Thank you, Tim. And you know, this is a really exciting time in acute myeloid leukemia. I last gave a similar talk in this forum about a year and a half ago, and really the significant advances that we've seen just over the past year in this disease has been fascinating and has really helped our patient population, and we're beginning to improve outcomes, particularly in older patients, which will be the focus of this talk today. So with that, again, the title of my talk is Management of Acute Myeloid Leukemia in 2020, which will be a bit of an update compared with the prior talk in 2018, Paradigm Shift for Older Adults. Here are my disclosures. So the objectives of today's talk are to discuss the pathogenesis and etiology of acute myeloid leukemia, which I'll refer to as AML moving forward, to discuss diagnostic testing in AML, to discuss the management of AML in older patient populations, again the focus of this talk in the context of recent drug approvals, and to highlight investigational agents in development and evolving treatment paradigms for older adults. We'll touch on some clinical trials and innovative aspects of this disease. So I'm going to first start with a case. This is a patient of mine that I've been taking care of for the last several years. He's a 75-year-old male. He had a past medical history of chronic myelomonocytic leukemia, or CMML, and hypertension. He presented to urgent care in October 2017 with lower extremity edema and fatigue. He was previously diagnosed with CMML in December 2016, so about a year prior to his presentation, where he was diagnosed with a white blood cell count in the 40,000 range, had monocytosis, no significant cytopenias, and a bone marrow biopsy at the time of his original diagnosis showed 1% blasts and trilineage dysplasia. He was not offered therapy at that time and was just being observed for further worsening of his blood counts. At presentation in 2017, this patient had a white blood cell count of 174,000, wide range of differentiation in the peripheral blood. His circulating myeloblast percentage was greater than 20%. He had a hemoglobin of 9.6, platelet count of 70,000, and his uric acid was very elevated at 12, creatinine was elevated at 1.3, and LDH was 1,659. Patient denied any symptoms of chest pain or dyspnea, and a bone marrow biopsy was performed at the time of this presentation showing acute myeloid leukemia with 31% blasts. He had normal cytogenetics, and a next-generation sequencing panel was within normal limits. He did not have any detectable mutations by our assay. So the first question here is, what is the appropriate next step in the management of this patient? A, 7+3 induction, since this patient has AML, and AML shall be treated with 7+3. B, IV fluids and leukapheresis. C, IV fluids, hydroxyurea, and allopurinol. Or D, IV fluids, hydroxyurea, allopurinol, and raspuricase.
All right, and again, all of these are anonymous, so take your best guess if you're not certain. And let's give our audience about 10 more seconds or so to go ahead and put in what you feel would be the most appropriate answer for this question. And all right, thanks for everyone to everyone for participating. How are they doing?
Yeah, and I think this talk hopefully will be instructive. The correct answer here is actually D. This patient should not be treated emergently for his AML with 7+3, and we'll get into the presentation as to why 7+3 would be actually the wrong answer choice in my opinion. Hydroxyurea is the initial cytoreduction that we give patients who present with a high white blood cell count with AML. The patient did not have leukostasis, so does not require leukapheresis, which is why B is incorrect. And given the fact that the patient is in active tumor lysis syndrome, we recommend giving raspuricase, a recombinant urate oxidase, as well as allopurinol as a xanthine oxidase inhibitor. So the correct answer here would be D. And then the next question, I sort of alluded to the first answer choice here, but what is the optimal treatment strategy for this patient? A, 7+3, B, CPX-351, C, Azacitidine, D, Azacitidine plus Venetoclax, or E, clinical trial. And again, those of you who work closely with me will know the answer choice that I would choose here. But I'll give people a hint. There's really only one incorrect answer choice.
Okay. All right, and take just about 5 more seconds if you would. All right, Dr. Zeidner, what answer were you looking for?
So the answer choice that I would choose would be E, a clinical trial. However, I think Azacitidine plus Venetoclax is a very reasonable treatment choice, which we'll discuss throughout the presentation. A is actually, I think, the most incorrect answer, 7+3, and we'll get into the reasons why I would not choose that. But you could theoretically choose B, C, or D as well.
All right, thank you. Thanks to everyone for jumping in and answering the poll.
So let's get into the pathophysiology of acute myeloid leukemia. What is AML? AML is a clonal proliferation of myeloid precursor cells in the bone marrow. These are termed myeloblasts. Myeloblasts are the most immature white blood cell produced in the bone marrow. All healthy individuals produce myeloblasts. However, myeloblasts rapidly mature into neutrophils, basophils, eosinophils, and macrophages that display our functioning immune system. In AML, these myeloid precursors or myeloblasts have a reduced capacity for differentiation, so they're not able to mature to become normal neutrophils, and they have a reduced capacity for cell death, leading to uncontrolled cellular proliferation, whereby the bone marrow is filled predominantly with these myeloblasts and no other normal functioning immune cells. The pathogenesis of AML is thought to arise from an early hematopoietic progenitor or stem cell. When a hematopoietic stem cell acquires what we term leukemia-initiating mutations, mutations that render that cell leukemic, that cell then becomes what's known as an LSC, or a leukemia stem cell. Stem cells have 3 basic properties. They're not cell cycle dependent, which we'll get into the implication of that. They are not capable of self-renewal, and they produce committed progenitor cells. In a schema here of how AML arises and how we treat AML, you can see that this early hematopoietic stem cell that acquires leukemia-initiating mutations is termed an LSC, or leukemia stem cell. This is the red and purple ugly-looking cell here. Ultimately, over time, this leukemia stem cell will lead to the clinical phenotype of AML, whereby myeloblasts are produced, these whitish cells, and cannot mature to become normal functioning immune cells. At the time of clinical presentation, when the patient has symptoms of AML and there are myeloblasts in the bone marrow, conventional chemotherapy or cytotoxic chemotherapy is generally given to these patients, which is fairly effective at getting rid of these myeloblasts, these proliferating cells in cycle. However, you'll see that even when a patient is termed to be in a complete remission here, where we don't see any of these myeloblasts present, these leukemia stem cells with the leukemia-initiating mutations can still survive chemotherapy and ultimately recapitulate this disease later on, whereby patients have a high likelihood of relapse. So stem cells are inherently chemoresistant, at least to our upfront cytotoxic chemotherapies, and the origin of the leukemia stem cell really dictates prognosis and ultimately drug resistance in these patients. How do we cure AML? The holy grail really of all cancer, and AML is not excluded there, is to cure these diseases. And the working hypothesis here is that AML arises from an early primitive hematopoietic stem cell termed a leukemia stem cell. The more primitive the leukemia stem cell is within the stem cell differentiated progeny, the harder it is to eradicate the stem cell, and these patients are more likely to have refractory disease and relapse disease. And the genetic features of AML really provide a clue for how primitive AML is, and we'll get into some of the classifications of genetically as this talk goes on. Clinically speaking, practically speaking, how do we diagnose AML? AML is diagnosed by seeing 20% or more myeloblasts in the peripheral blood or bone marrow. The myeloblast percentage is irrelevant in two distinct features of AML. One is core binding factor AML. Those are patients with translocations in chromosomes 8 and 21 or inversion 16 or translocation 16-16. Or acute promyelocytic leukemia, or APL, the percentage of myeloblasts is also irrelevant in that subgroup of AML. How do myeloblasts, or leukemic myeloblasts for that matter, look morphologically? This is a representative picture from a bone marrow aspirate here, where you can see all of these ugly, immature looking cells are all myeloblasts. They're usually very homogeneous looking. They have smooth chromatin, prominent nucleoli. You can occasionally see hour rods, which are pathognomonic for a myeloid leukemia, but not always seen in acute myeloid leukemia. How do we differentiate acute myeloid leukemia from other acute leukemias? It is really impossible morphologically to diagnose AML in this picture compared with, let's say, acute lymphoblastic leukemia, whereby the blasts can look very similar to each other. So we rely on something called the immunophenotype, which is flow cytometry looking at the cell surface antigens of the circulating cell to determine the cell origin, whether the cell is a myeloid cell or a lymphoid cell. Early myeloid, immature myeloid antigens are commonly seen with myeloperoxidase, CD13, CD33 expression. So if we see that those cell surface markers expressed on these cells, we have a high likelihood of that patient having acute myeloid leukemia. Sometimes acute myeloid leukemia can be differentiated to be more monocytic, and there are specific monocytic antigens that are shown here. And nondescript blast markers include CD34 and CD117, which are commonly seen on the cell surface of these immature blasts. Epidemiology of AML. There are about 18 to 20,000 new cases of AML each year in the United States. More than 10,000 of these patients unfortunately die each year with this disease. The median age of AML is 67 to 68 years. But as you can see in this incidence curve, the incidence increases with age. And it doesn't really ever plateau. Even as patients get over the age of 90, the incidence we see of AML increases with age. All ages are affected. However, predominantly you can see the 60 and over group here very prevalent for the AML population. How do patients present with AML? There are really two different classes of presentation with AML. The first is more commonly seen in younger patients, whereby these patients present very rapidly, typically over 1 to 2 weeks, with common symptoms of bone marrow failure. Again, in the bone marrow, there are really, in many cases, no normal cells. And so these patients can present with profound anemia, non-specific symptoms of anemia like fatigue, weakness, malaise, dyspnea on exertion. Many of these patients are profoundly thrombocytopenic and can present with mucosal bleeding and bruising. And these patients have compromised immune systems, so generally can present with fever or infections. The other presentation that can be seen in AML more commonly in older patients is a more protracted subacute or gradual presentation of symptoms, typically weeks to months, whereby many of these patients may have had a pre-existing myelodysplastic syndrome, which is beginning to transform and evolve into acute myeloid leukemia. So how are these patients classified, and how do we prognosticate patients with AML? The old classification system, which is now outdated for about 10 to 15 years, was the French-American-British classification, or FAB, which really subclassified patients into 8 different risk groups based on the immunophenotype and the morphology of the blasts to be M0 through M7. But now that we have real sensitive genetic testing and more prognostic means for these patients genetically, FAB classification has really gone by the wayside. There are a few different classification systems that are utilized in AML, but I think the most widely used classification system is the European Leukemia Net classification that is shown here. This was revised in 2017, and we have 3 different risk groups in AML: a favorable, intermediate, and adverse risk group. These risk groups are determined by the cytogenetics and the mutations that are present at diagnosis. And you'll see here that the risk group that patients are more commonly seen in patients is determined by the overall age group. In AML, we kind of have a line in the sand where we divide younger and older patients. Younger patients are generally thought to be less than 60-year-olds for the purposes of classification, and older patients or elderly AML are generally those over the age of 60 to 65. You can see favorable risk AML is more commonly seen in younger patients, whereas adverse risk AML is more commonly seen in older patients, as shown here. Why do these risk groups matter? This is an older analysis from the previous European Leukemia Net classification that was devised in 2010, which actually had 2 intermediate groups, intermediate 1 and 2, and now we have 1 intermediate group, so both 1 and 2 is kind of constrained within the 1 intermediate risk group. But as you can see here, these are younger patients, less than 60-year-olds with long-term Kaplan-Meier curves, long-term survival Kaplan-Meier curves. And you can see here the red line represents adverse risk patients, and again, these are younger patients. Median survival is less than a year for younger patients who have adverse risk disease, whereby you can see favorable risk patients with the blue line here have a 50 to 60% long-term survival. So it's really critical to underscore the risk group that patients fall into for short-term and long-term implications. AML is a very heterogeneous disease, and it is really irresponsible to just denote a patient of having AML without understanding the genetic features of their leukemia. About 10 years ago, some of the first mutational analyses were done in AML from large cooperative group settings, and this figure here really shows the most common mutations seen in AML. The 3 most common mutations are FLT3, NPM1, and DNMT3A. And this is a Circos plot where you can see that each mutation that's present is commonly associated with other mutations, and these gene-gene interactions are really critical to understand the biology and the prognosis of the disease. For instance, NPM1 mutations, which are seen in about 30% of AML, are shown here. About a quarter of these patients also have DNMT3A mutations, and about a third of these patients also have FLT3 mutations. And understanding what other mutations are present along with the dominant mutation is really critical for therapeutic purposes. This figure illustrates that we are slicing we have smaller slices of the pie, so to speak, as we subclassify AML patients and understand the biology of this disease. Smaller cytogenetic risk groups have very different biologic features and different mutations at play, so it's really important to understand both the cytogenetic and the molecular features of this disease. A few years ago now, the largest genomic classification system was devised in AML patients. 1,500 AML patients had cytogenetic and very deep sequencing to understand the biologic drivers of this disease. And the authors devised 11 genomic classes of AML, which are shown here. The most common genomic subgroup based on this analysis were those with an NPM1 mutation, which was seen in about 27% of patients. And again, you can see the variable associations with other mutations along with NPM1. I think more importantly, what this analysis uncovered is that there are certain drivers of this disease that confer very poor prognoses and other drivers that may confer more favorable outcomes. For instance, inversion 3 is a chromosomal abnormality that is fortunately only seen in 1% of AML patients. But those that have an inversion 3 have dismal outcomes with a very high hazard ratio of death, and it is very important to understand this and to detect this at diagnosis. Secondly, TP53 mutations are a bit more common, seen in about 6% of AML patients, and also confer very poor outcomes. In contrast, NPM1 mutations are fairly common. 28% in this analysis had of patients had an NPM1 mutation, and NPM1 generally confers a more favorable risk outcome. CEBP alpha biallelic mutations also have a more favorable outcome, and inversion 16 is the core binding factor, one of the core binding factor abnormalities. Again, you can see more favorable outcomes in patients with this disease. Again, the gene-gene interactions here are really critical. As I just mentioned, that although NPM1 mutations may overall have a favorable outcome in patients compared with those that don't have the mutation, but if you have an NPM1 mutation and a FLT3 ITD mutation and a DNMT3A mutation, which the composite is seen in 6% of AML patients, you could see a much less favorable outcome, in fact, an adverse risk outcome with a higher hazard ratio of death. So if you have this triple mutational analysis, that confers worse outcomes. So it's important to know the entire composite and complexity of mutations that are present at baseline. At University of North Carolina, we do a next generation sequencing panel in-house of about 33 genes. These are the most commonly mutated genes in both MDS and AML. We perform this test in all diagnostic bone marrow aspirates before patients undergo treatment. We recheck this at the time of relapse, and that's an evolving area in our field to interpret these data over time and to see the evolving changes. These mutations can be either prognostic, therapeutic, which we'll get into, or in some cases like NPM1 mutations may be able to be detected in those who have minimal residual disease and can be used serially to follow deep sequencing analysis and detection of disease. So getting into the clinical outcomes of AML patients, unfortunately, despite the therapeutic advances in this disease, AML patients have a very poor prognosis with conventional chemotherapy. The most important prognostic factor in AML, beyond all the genetics, is actually age. You can see here from these 5-year survival curves, which were adapted from the SEER database. Once patients get over the age of 45, the long-term survival decreases substantially as patients get older. Again, we divide patients in AML into younger and older subgroups, and in this analysis, those younger than 65-year-olds out of about a 5-year survival of all comers in the 50% range, maybe 40 to 50% in those less than 65. But in those 65 and over, the long-term survival in AML is less than 10%, very few long-term survivors, and this really represents the highest unmet need in AML. So we're going to get to the next question here, which will kind of set the stage for some of the subsequent slides here. Have overall outcomes improved in AML patients over time? A, no long-term survival has not changed over time. B, yes, long-term survival has improved steadily since the 1970s in both younger and older patients, but this is not due to chemotherapy. C, yes, long-term survival has improved since the 1970s in younger patients, due in large part to supportive care and transplant, but much less so in older patients. Or D, yes, long-term survival has improved steadily since the 1970s in both younger and older patients due to more effective chemotherapy.
All right, so lots to think about, and nice to see this really moving around as people evaluate or reevaluate and get settled on their answers. Take just about 5 more seconds, if you would, to go ahead and put what you think is the best choice in there.
Well, I think people are answered it perfectly. So C is the best answer here, and this will be best illustrated in this subsequent slide here. This was an analysis, a very intriguing analysis that was done by the Medical Research Council Group of the United Kingdom, where they looked at long-term survival in patients with AML that was diagnosed in different decades between 1970 and 2009. And they looked at these long-term survival outcomes in 2 subgroups, those younger than 60 years and those 60 and over, so the younger and older subgroup. The first figure on the left here shows the long-term survival in the younger subgroup, less than 60-year-olds. The black line here represents the 1970s, where most of these patients were dying, unfortunately, of their disease, 5% long-term survival, all the way up to 2009 in purple, where you can see here 47% long-term survival. So we are seeing steady improvements in survival over time from the 1970s in younger patients. However, that is not due to more effective chemotherapy. As I'll show you in the subsequent slide, this improvement is actually due to the refinement of antibiotics, supportive care that we're able to maintain patients through intensive chemotherapy approaches, and the successful refinement of allogeneic stem cell transplant as a potential curative option for these patients. In comparison, you can see older patients have much less improvement of survival over time, maybe seeing a slight blip up in the 2009 era, but really pales in comparison to the younger patients' improvement in outcomes. So we have not really seen effective chemotherapies in this disease since the 1970s, believe it or not. The mainstay of chemotherapy, intensive chemotherapy for AML patients, which is predominantly given to younger patients, is a composite of 2 drugs known as 7+3, 7 days of cytarabine and 3 days of an anthracycline. And this was a regimen that was developed in the 1970s and has really changed very little since the 1970s. We have not really seen any effective chemotherapy drugs approved for this disease, with few exceptions, from the 1970s all the way to 2000. 2000, a drug called gemtuzumab ozogamicin, which is an antibody drug conjugate to CD33, was approved in 2000 and then actually taken off the market in 2010 due to concerns about toxicity. However, in 2017 until most recently, actually, we've had 8 new drugs approved for this disease, moving towards more of a personalized cancer therapy approach, whereby we have targeted treatment options for specific subgroups of patients that would really benefit from these treatments. So we're beginning to see the fruits of our labor, I believe, as we're understanding this disease biologically. We are seeing treatments advance to improve overall outcomes. So the next question is, why do elderly AML patients, again defined typically those over the age of 60 to 65 years, why do they have worse outcomes than younger patients? Is it because older patients are more frail and less apt to tolerate the intensive chemotherapies that younger patients can? Is it because they have a higher proportion of adverse risk disease, which do worse than favorable risk? Is it because they have a higher proportion of secondary AML? Is it because of treatment nihilism? Or is it all the above?
And again, take just about 5 more seconds to go ahead and put in your best answer. All right, Dr.
Right, and so I agree with all the above. I think that's mostly everyone answered that correctly.
Right. Let me just put in at this point that I'll go ahead and open up poll everywhere so that you can go ahead and start submitting your questions, and then at the end of the lecture, Dr. Zeidner will answer as many of those as we have time for. So
Correct.
I'll switch that over and you can start putting in your questions now.
Yeah, so elderly AML patients have worse outcomes than their younger patients for all the reasons stated. They tend to be more frail as you get older, more comorbidities, of course less apt to tolerate intensive chemotherapy. But it is more than just that. The biology of this disease in older patients is much different than younger patients. They have a much higher risk of having adverse risk disease and mutations that confer what we call chemo resistance, such as TP53 mutations. And even the same risk group, if you compare it from a younger patient to an older patients do not benefit as well to the standard chemotherapy drugs that younger patients do. Older patients have an increased incidence of secondary AML from pre-existing MDS, which has a very poor prognosis. And I think, importantly, there have been a lack of effective treatment options for this patient population and a significant degree of treatment nihilism in the community for this patient population. The treatment nihilism aspect is really illustrated here by an analysis from Amr Zeidin and colleagues published last year. This is a retrospective analysis from the SEER database over 12-year time period, 2001 to 2013, whereby over 14,000 AML patients were diagnosed in this time frame, and these were all older AML patients, 66 to 99 years old. And what the authors did was analyzed and assessed how many patients were not being treated at all for their disease. And if you look here in 2001, 60% of patients diagnosed between the ages of 66 and 99 years in AML, 60% of these patients were not offered any treatment of their AML. In contrast, 2013, we're seeing maybe a trend of more patients being treated with chemotherapy, so 43% of patients over the age of 65 are not being treated for their cancer. So more patients now, about 60% of patients are being treated for their leukemia. But this is a too high of a percentage, as we have multitude of studies that show that any chemotherapy for older patients improves outcomes compared with no treatment. So we have to do a better job at educating our community that these patients should at least be considered for treatment options and should be referred to academic cancer centers for consideration of treatment options. So what are the treatment options for elderly AML patients? I'm first going to touch on intensive chemotherapy. Intensive chemotherapy is really the mainstay of treatment for younger patients. But for older patients over the age of 60 to 65 years, this is really used with caution. Older patients have worse outcomes with intensive chemotherapy. This is an older analysis here, but if you subdivide older patients by ECOG performance status, a 0 are those who are very fit and have really no limitations, a 3 are very unfit patients. Even older fit patients with an ECOG performance status of 0 have treatment-related mortality over 10% with intensive chemotherapy. In fact, in the 66 to 75-year group, you can see here 12% of these patients will die within 30 days if they're given intensive chemotherapy. That might be a risk that some patients would be willing to take if the treatment was very effective. But it turns out the treatment's not very effective. Intensive chemotherapy in patients over the age of 65, the chance of achieving a remission for all comers in this analysis was less than 40%. So these patients have less than a 40% chance of achieving a response and on the upwards of 10 to 20% chance of dying from their treatment. So this is not something that should be universally recommended for older patients. We do recommend intensive chemotherapy in select scenarios for those over the age of 65, particularly those with favorable risk features that may have a higher likelihood of benefiting from these treatments. But this analysis really underscores the dilemma of treating these patients intensively. Now, CPX-351 is a new drug approved for this disease in the past few years. CPX-351 is actually a liposomal formulation of 7+3. So it is cytarabine and daunorubicin in a liposome, and this was designed to mitigate the toxicity of 7 and 3 and improve overall efficacy. It is true intensive chemotherapy. The clinical activity of CPX-351 was compared with 7+3, the standard intensive chemotherapy in older patients, and it was shown to be beneficial, particularly in achieving higher response rates. But in this randomized phase 2 study, secondary AML patients appeared to have the most benefit. So this led to the design of a randomized phase 3 study of CPX-351 versus 7+3 in newly diagnosed AML with MDS-related changes, therapy-related AML, AML from pre-existing chemotherapy, or secondary AML from pre-existing MDS, and these were done in older patients 60 to 75 years. You'll see here this is the criteria that we use to define AML with MDS-related changes. This is defined by the presence of pre-existing MDS or having morphologic multilineage dysplasia, having 50% or more dysplasia in 2 or more lineages in the bone marrow, or having the presence of any of these MDS-related cytogenetics as shown here. So in this analysis, CPX-351 led to superior outcomes compared with 7+3. You can see the survival numbers here, 9.6 months with CPX versus 6 months with 7+3. Higher chances of achieving a CR with CPX versus 7+3, 48% versus 33%. and CPX-351 led to superior outcomes post-transplant. So, based on this data, CPX-351 was FDA approved for the management of patients with AML with MDS-related changes based on the criteria I just mentioned, treatment-related AML, or AML from pre-existing MDS. There is no age restriction on the label of CPX-351, but these studies were only done in 60 to 75-year-olds. So I would be very cautious treating a patient over the age of 75 with CPX-351. There are studies ongoing in other patient populations, such as younger AML patients and other risk groups. But ultimately, this study really highlights, I think, that 7+3 is not a useful comparator here. There were dismal outcomes seen with 7 and 3 in this patient population, and so I think some of the more contemporary studies will compare CPX to other strategies that we'll get into. I do think that CPX-351 is a new standard of care for this patient population, but really moves the needle slightly, and we need better therapies in this patient population. So we're going to shift gears to low-intensity strategies here. Multiple studies have shown that any treatment leads to improved survival compared with best supportive care alone in AML. Some of the early studies were done with an old drug called Cytarabine, whereby low doses were compared with best supportive care. And yes, low-dose Cytarabine leads to improved outcomes compared with best supportive care, but we're talking about modest improvements in a survival that's still measured in 6 months. Hypomethylating agents, which will be the focuses of the remainder of the talk, include agents such as azacitidine and decitabine. These are actually not approved for AML. They're approved for MDS, but have been used as standard of care in the United States for more than 10 years and are approved in Europe for AML. But combination therapies are really now leading to superior outcomes and are changing the paradigm for these patients. I'm going to quickly go through, based on the time here, I'm going to quickly go through some of these studies assessing hypomethylating agents in AML. The first is a randomized phase 3 study that looked at decitabine given for 5 days versus physician's choice. Physician's choice was either low-dose Cytarabine, the old standard of care, or just best supportive care, no chemotherapy, for newly diagnosed older AML patients over the age of 65. This is a very large study, 485 patients, older patients. Favorable risk patients were excluded from this study. You could see very modest CR rates with decitabine, 18%, and the overall survival comparison on this study was 7.7 months versus 5 months, 7.7 months with decitabine. This did not quite reach statistical significance and therefore was not FDA approved. And thereafter, the Ohio State group thought that intensifying decitabine by giving 10 days instead of 5 days might improve overall outcomes in these patients. And so a very small study, 53 patients, was done with 10 days of decitabine in older patients. You can see the CR rates were dramatically better. It was not a comparison study, but 64% CR rates, and median survival was about a year. However, subsequently, a randomized phase 2 study was done at MD Anderson comparing the 10-day approach to the 5-day approach with decitabine, and there was no difference in overall outcomes between both regimens, thereby really tempering the enthusiasm of 10 days of decitabine, and I think underscoring the need and role for randomized clinical trials in this setting. Azacitidine is probably the most common hypomethylating agent used in AML, and a randomized phase 3 international study was done a few years ago comparing azacitidine to physician's choice. Physician's choice included 3 different arms. The physician would choose between an intensive chemotherapy approach, low-dose Cytarabine, or best supportive care as the options for these patients in patients over the age of 65. Again, very large study, older patients, comparing azacitidine to the composite of physician's choice. There's really no difference in response rates, 28% versus 25%, but the 25% in the physician's choice arm of response rate was really enriched by the intensive chemotherapy approach, leading to a 47% CR rate. There was a statistically significant improvement in survival with azacitidine that was only done when patients were censored for subsequent treatment, which was actually a pre-specified analysis. So the median survival with azacitidine was about 10 months. But again, I think the most relevant aspect of this study was comparing patients who got intensive chemotherapy to those that got azacitidine. That was a subset from this study. And you can see of the 87 patients randomized on that subset, there was no difference in survival between azacitidine or intensive chemotherapy. Intensive chemotherapy led to higher response rates, but no difference in overall outcome. So the question is, should 7+3 be used at all in the elderly based on this analysis? So HMAs, hypomethylating agents, are reasonable first-line strategies for older AML patients, particularly those who are not bone marrow transplant candidates. We don't have the data comparing HMAs to CPX-351. HMAs are generally less toxic than intensive chemotherapy. There are many disadvantages, however, to HMAs. And the question is, how can we leverage these results to improve overall outcomes? And that comes with a new agent called Venetoclax. Venetoclax is an inhibitor to BCL2. BCL2 is a cell survival protein in the body that basically inhibits what we call the intrinsic pathway of apoptosis. When cells upregulate BCL2, this leads to cell survival, and leukemia cells and other cancer cells really upregulate these signals in order to survive. Venetoclax blocks that survival signal and leads to apoptosis. Initially, there was some modest response rates seen with a single agent of Venetoclax given by itself in relapsed refractory AML patients. But subsequently, there was preclinical studies that really suggested synergy between Venetoclax and hypomethylating agents. And a phase 1 study was done in newly diagnosed older patients over the age of 65 with HMAs plus Venetoclax, and these were patients who were not eligible for intensive chemotherapy. These patients got either Decitabine or Azacitidine. Venetoclax was ramped up to a dose of 400 milligrams daily, and it was shown to be safe and feasible. And here are the results of this study. Older patients, again, 74 was the median age. Most of these patients had non-secondary AML or de novo AML. The CR rates with 145 patients treated with this combination was 67%. And the median duration of response was a little less than a year. Median survival on the study, 17.5 months, and there were similar CR rates between azacitidine and decitabine. There are some subgroups of patients that really don't benefit much from Venetoclax and azacitidine, and those are patients with TP53 mutations that really had much worse outcomes when compared with the other subgroups. So based on this promising data, again, this was a non-randomized, non-comparison study, a phase 1b study. Venetoclax was given accelerated FDA approval for the treatment of newly diagnosed AML patients in combination with HMAs. This is done for patients over the age of 75 or comorbidities that preclude intensive chemotherapy. And the question is, does this represent a new standard of care for elderly AML patients? I think there are many questions here. With Venetoclax, it is very challenging to give this drug in the community. The dose has to be ramped up over 3 to 5 days. Many of these patients have to be hospitalized in order to achieve the steady state dose. Myelosuppression is very frequent with Venetoclax, and we don't really know how to dose this drug in cytopenias. There's lots of drug interactions, and so because of the approval of this drug being given so early without all the data, I think it lends itself to many challenges in the community. There are 2 ongoing randomized phase 3 studies being performed right now, one being azacitidine plus Venetoclax versus azacitidine alone, and that is powered for an overall survival to really see if the addition of Venetoclax improves overall outcomes despite the promising results that we're seeing from these early phase studies. The next question is, what do we do when patients stop responding to Venetoclax? And yes, this combination is very promising and leads to encouraging response rates up front, but most of these patients will ultimately relapse. And when patients relapse or don't respond in the first place to Venetoclax plus hypomethylating agents, the median survival is less than 2.5 months in this patient population. So this really represents a very urgent, high unmet need for this patient population. In those with targetable mutations, FLT3, IDH1 or IDH2 mutations, we have oral drugs that can be offered for those patients, but the majority of these patients do not have targetable mutations, do not have subsequent treatment options that can benefit them. Some of the investigational approaches here, which are based on the biology of this disease, is targeting a pathway called MCL1. MCL1 is another cell survival signal for AML patients and appears to be a resistance mechanism to BCL2-mediated therapy. We are fortunate to be the lead site here at University of North Carolina for a very exciting randomized phase 2 study of alvocidib, which is a CDK9 inhibitor that leads to suppression and inhibition of MCL1 with or without low-dose cytarabine. It's a randomized study in patients with relapse refractory AML after Venetoclax first-line treatment. So this will hopefully lead to potential future options for patients who have resistant disease after Venetoclax, and we're really excited about this study. There are a number of other low-intensity strategies that can be offered in newly diagnosed elderly AML patients, some of which are summarized here. Glastagib is a hedgehog inhibitor that is approved in combination with low-dose cytarabine, but because the comparator on this study was low-dose cytarabine, it is really hard to generalize these results to hypomethylating agents, and so it is not really commonly used in the community. Venetoclax can also be combined with low-dose cytarabine, and I think the patient population that would be best in that scenario would be those who have had prior HMAs for MDS and other malignancies. And finally, ivosidenib is an IDH1 inhibitor. It's approved in relapse refractory and newly diagnosed AML patients with an IDH1 mutation. IDH1 mutations are only seen in about 5 to 10% of AML patients, and the approval in newly diagnosed AML was based on a very small subset analysis of 34 patients. You can see response rates of 42%, median survival of a little over a year. The data looks promising, but we don't really know how this compares to a Venetoclax-based strategy. So I think that this is Venetoclax and some of these other targeted treatment approaches are really leading to a paradigm shift in the way we think about managing elderly AML patients and how these patients do with their disease. Treatment nihilism has really existed for elderly AML patients in the community for decades. We now have a multitude of available agents that I think are beginning to confer improvement in outcomes. Our low-intensity treatments are evolving and perhaps even shifting to younger patients as we're seeing such encouraging responses. There's no reason why we shouldn't shift our gears to treating younger patients with these strategies as well. I think biomarker-based approaches are really critical here to underscore which patients are going to respond to these agents versus which patients will be resistant. And genomic sequencing is critical to really inform these treatment decisions, as future treatment strategies will likely be based on full sequencing panels. This is just to summarize and end with a plug about clinical trials. I think despite all these treatment advances, why is my answer choice E, clinical trials, the best option for the patient that I alluded to, a 75-year-old with newly diagnosed secondary AML? We don't really know the long-term outcome of patients on these treatment options. Even Venetoclax was approved based on a relatively small phase 1 study. We need to do a better job of determining which patients are going to benefit from some of these strategies, and ultimately, notwithstanding improving overall outcomes, we also want to mitigate toxicity and improve quality of life in older patients with AML. We are fortunate at UNC to also be part of the Beat AML initiative. This is a multi-institutional precision medicine-based clinical trial sponsored by the Leukemia and Lymphoma Society, and this is offered to all older AML patients over the age of 60, whereby these patients will have genomic profiling done within a week, and multiple investigational treatment arms will be allocated based on the genomic profile to predict or to hypothesize which patients might benefit from different treatment strategies based on the biology of their disease and their genomic profile. This is a figure taken from the most recent ASH presentation showing that those patients who enroll on Beat AML, the solid black line here, have had really encouraging outcomes compared with those enrolling on just standard treatment strategies. This is a phase 2 clinical trial that we had open here and have subsequently closed recently, combining azacitidine with a monoclonal antibody targeting PD-1 known as Pembrolizumab. This was being given to patients with newly diagnosed older AML patients as well as relapse refractory AML. We have very encouraging response rates on this study. This is in collaboration with Johns Hopkins and one of my colleagues, Ivana Goyo, whereby we're really interested in determining biomarkers of response to immunotherapies like Pembrolizumab in AML. So we're going to go back to the case and end here. So what happened to my 75-year-old? So after cytoreduction and management of tumor lysis syndrome, the patient actually enrolled on the prior clinical trial that I alluded to, a phase 2 study of azacitidine plus Pembrolizumab. The patient achieved a complete remission after 2 cycles of treatment, and he's been in complete remission since November 2017. He's had no hospitalizations after just that first hospitalization where he was diagnosed. He's completed 2 years of therapy with azacitidine and Pembrolizumab, has had no side effects to either treatment except he now has hypothyroidism requiring thyroid replacement from the Pembrolizumab. He has a normal quality of life. He has no limitations. He's currently 77 years old and is continuing to receive azacitidine, which I think is really unprecedented in this patient population. So in conclusion, AML is a challenging disease to treat, very heterogeneous with diverse genetic subsets that inform treatment decisions. Elderly AML patients now have many different treatment options and should be referred to specialized centers. Targeted treatment approaches will continue to move this field forward and lead to improved patient outcomes. Venetoclax-based treatment is really leading to a paradigm shift in the management of elderly AML, but the questions remain: who is best predicted to respond to these treatments, which patients will be resistant, and there are some biologic correlates that have been recently published that can answer some of those questions. And what do we do after patients receive venetoclax? I think clinical trials are imperative in all facets of this disease, and I really encourage community physicians to talk to us and refer their patients, particularly older patients with AML, so that we can discuss some of these strategies with our patients. I'll close there, and I put my email up, and I'm happy to answer any questions anyone has about AML. I'm always available and happy to talk. So thank you.
Great. And Dr. Zeidner, we have quite a few questions. I'll go ahead and start posting those. First one here, that should be visible. Let me make sure. Let me go ahead and reactivate that, see if we can get that. If not, I'll read that off. Let's see. Well, for some reason,
I think I saw, what is the prognostic value of IDH1?
Yeah, let's see if we can get that one up again. And again, if not, if this is not cooperating, we'll go. Let me bump this over and reactivate it here. No, I'm just going to go ahead and not do that because we don't want to do that. But I'll go. Okay, here we go. So, what is the prognostic value of IDH1 mutations?
So, IDH1 mutations are not incorporated into our prognostic classifications. They're considered neutral prognostically, so they're certainly not adverse risk. What's notable about IDH1 mutations are that we can target them with ivosidenib, an oral IDH1 inhibitor. And so I think that really the IDH1 itself is not particularly favorable or adverse prognostically, but the other mutations along with IDH1 really dictate the biology of the disease.
Great. And our second question, any role or data of immunotherapy for AML?
Yes, that would be a completely separate talk that I'm happy to do at some point. Standard of care, the answer right now is really no. We are at the forefront of studying checkpoint inhibitors and different immune checkpoint blockade strategies in AML, where we have a number of ongoing trials that look very promising. One of them I alluded to with azacitidine and Pembrolizumab. There are certainly what we call bispecific antibodies that help harness a CD3 T-cell effect next to the leukemia, and what we call dual antigen receptor targeting and CAR T-cells that are being explored in AML, but nothing that is standard of care right now other than antibody drug conjugates with gemtuzumab, which is a medieval term for immunotherapy. or medieval form, I should say, of immunotherapy.
Okay. And is TP53 considered a genetic predisposition that can be passed from parent to child?
It could be. Most of the time, no. There are genetic syndromes where patients are born with a TP53 mutation. Those are very rare. A syndrome called Li-Fraumeni, for instance, has acquired, or patients are born with TP53 mutations, and you see lots of different cancers at a young age. But most of the TP53 mutations that we detect in AML are in older patients and are not genetic. They're not passed down to their family. They're not inherited.
Thank you. Will immunotherapy alone or in combination with HMAs play a role in the treatment of elderly patients with AML in the future?
I think so, yes. Again, that would, there's a lot of data there to discuss. There have been a number of studies done with different PD-1 inhibitors and PD-L1 inhibitors. There was actually a randomized phase 2 trial of azacitidine plus durvalumab, which is an antibody to PD-L1, versus azacitidine alone in newly diagnosed older AML patients. That was a completely negative study and was recently presented at ASH. So I think that where I think this field would move forward with immunotherapy combinations are biomarker driven. Can we determine which patients are going to really respond or have some immune phenotype that can respond to these agents? And some of those studies are ongoing. I think it will have a role, but we're really at the early stages of developing these agents.
Great. And we do have more questions, but I'm afraid we need to leave it there because we are running out of time. So I just want to say a few thank yous. Thank you to the Lineberger Comprehensive Cancer Center, UNC, for all of their support of this program. Thank you to the North Carolina General Assembly for their generous support of the University Cancer Research Fund. Thank you to Mary King, Veneranda Obore, and John Powell on our team for all of their hard work to make every one of these lectures happen. As always, we have more lectures coming up, Meeting the Needs of Undocumented Patients with Cancer. That's with Julia Rodriguez O'Donnell, and that will be on March 11th at noon. And then another one in this series, Research to Practice Cancer Immunotherapy Toxicities, Identification and Management in North Carolina, Updates in 2020, and that's with Dr. Fran Colicchio on March 25th at noon. So we hope you'll be here for that. We have our community, or our RN and Allied Health, Nutrition and the Aging Brain with Cancer Care with Melissa Walter. This is in our self-paced courses. Also in our self-paced courses now, New Indications for Radiotherapy with Dr. Wang. We've always got more lectures showing up, and you can take those anytime, day or night. Basically, Dr. Zeidner's lecture will be available for a year after this presentation, coming up in just a few weeks, and you can let your friends and colleagues know about this and go get free credit and view and benefit from that. Patient-centered care. This is another self-paced lecture, The Benefits of Exercise for Cancer Patients. We do have our Cancer Conversations series coming up this Friday at noon, Understanding Ovarian Cancer. That's a not-for-credit series for the community. You know where to find us, unccn.org, 919-445-1000. Thank you so much for being here today. Dr. Zeidner, thank you. We really appreciate it. This has been great. And we'll see you next time. Thanks.